Mess with the bull, you get the horns. The first reported case of disseminated histoplasmosis mitral valve endocarditis in Florida. Histoplasmosis is a dimorphic fungus that is prevalent in the eastern part of the U.S., primarily in the Ohio and Mississippi River valleys. It causes infection by inhalation of its spores. Only about 1% of patients infected will develop pulmonary symptoms or disseminated infections, such as endocarditis. In our case, we have a 61-year-old immunocompetent male with a history of diabetes, hypertension, and AFib who presented with an 8 to 10 month history of fatigue, low-grade fevers, and unintentional weight loss of 50 pounds. Of note, the patient works as a commercial residential building supervisor, and he also owns a 16-acre farm and raises bull calves as a hobby. He denies any recent travel, and he's originally from Florida. The etiology of his symptoms was presumed to be infectious. Imaging started to tell more of the story. As you can see here, the abdominal CT shows bilateral adrenal masses as large as 4.5 centimeters. A biopsy and a microbial cell-free DNA test was revealing for histoplasmosis. Additionally, there was concern for dissemination. Therefore, cardiology was consulted and performed a transesophageal echocardiogram, which revealed a large vegetation on the anterior leaflet of the mitral valve, as you can see on the right-handed image here. Pathology from the aortic valve confirmed diagnosis of mitral valve endocarditis from disseminated histoplasmosis. With the confirmation of diagnosis of histoplasmosis endocarditis, the patient was initially started on IV liposomal amphotericin for 14 days. The patient then underwent a successful mitral valve replacement with the cardiothoracic surgery team. He was soon stable for discharge and was discharged home on an azole maintenance treatment with a close follow-up with the Cardiology and Infectious Disease Service. Additionally, the Department of Health was notified in order to collect soil samples from his bull farm, as this remains the leading culprit of exposure of his infection. A recent systematic literature review revealed 80 cases of endocarditis secondary to histoplasmosis in the medical literature from 1940 to 2020. Although histoplasmosis has been seen in the northern parts of Florida, after a review of much of the literature, there are 0 reported cases of histoplasmosis endocarditis in the state of Florida. Below, you will see the outbreak locations of histoplasmosis from 1938 to 2013 per the CDC. As you can see, there are 2 outbreaks noted in Florida. However, none of these outbreaks included patients with histoplasmosis endocarditis. For confirmation of diagnosis, histopathology should be performed in tissues, where in our case, we had a biopsy from the adrenals and the aortic heart valve. As you can see here, there are atypical and typical yeast from the dimorphic fungi noted. You can see small rounded budding yeast and hyphae, which confirms the diagnosis. Histoplasmosis endocarditis is essentially fatal without combined surgical and antifungal treatment, with 100% mortality reported in literature review. The mortality for native and prosthetic valve endocarditis was 50% for patients receiving only antifungal therapy. Antifungal therapy combined with surgical intervention had a 0% mortality, as seen in our patient. Our case highlights the importance of a thorough history taking in patients with an infectious source with an unknown etiology to assess for all risk factors. This patient's exposure history can explain an infection that has never been seen in the state of Florida. Additionally, it highlights the efficacy of the treatment when combination therapy is performed.